So you may begin any time. Please identify yourself and your position with the Cardiologists Association for the purpose of the answer. Thank you.
Thank you very much. Madam Chair, on behalf of the Ontario Association of Cardiologists, I'm here today to discuss some of the thoughts that we have on the upcoming budget. To let you know, I'm a clinical cardiologist who's been practicing in Ontario for over 38 years, so I'm an old cardiologist. And I'm here speaking on behalf of the Ontario Association of Cardiologists. We are a voluntary professional organization representing Ontario cardiologists. Our board and members work each day with the provincial government, the Ontario Medical Association, and the Ministry of Health to maintain and to improve and protect the quality of cardiac care that residents enjoy in this province today. The OAC exists independently of the OMA to ensure that the voice of cardiology is heard loud and clear regarding issues that affect the care of cardiac patients in Ontario. While all cardiologists in Ontario are mandated to be members by government of the OMA does not provide its section on cardiology with the financial resources nor the infrastructure to allow it to act as an effective advocate for cardiac patients in this province. The OAC fills this gap, and without its ongoing advocacy program, the continued high standard of cardiac care that you enjoy in Ontario would be at serious risk. Our membership, as you know, is quite diverse. It comprises community cardiologists and entire academic health science centers in cardiology. And we represent more than half of the cardiologists who are registered in the province of Ontario. So I'm here today to share with you our priorities and some recommendations that we think are important for you to consider as you're moving forward on your budget so that we are protecting the cardiac patients in this province. The first is to address the impacts associated with the January 2015 unilateral government cuts to physicians, and especially as it affects cardiologists. These massive cuts that were announced on the 13th of January begin to take effect for cardiologists this weekend on the 1st of February. And a 3.15% cut in fees across the board goes into effect. On April 1st, and this is no April Fool's joke, the elimination of the Chronic Disease Assessment Code, and pay particular attention to this, E078, kicks in, and further cuts to fees paid to doctors with this, using this code, go into effect. At the same time that things are happening there, your government, or my government here in Ontario, is underfunding the expected 2.75% growth in costs associated with the delivery of medical care in our province. And medical care includes cardiology and cardiac care. And for those of you in the room, never forget that time is muscle. And when we lose time, we lose muscle, and patients die. The other thing the government has forgotten is that the influx of new people who come into Ontario, and there's a tremendous burden of cardiac disease in the people who are moving into this province. Be aware of it. There's at least 140,000 new people coming into this province from all over, and many of them are bringing a tremendous burden of cardiac disease, which we have to deal with. The government's elimination, April 1st, of the Chronic Disease Assessment Code, E078, which cardiologists use when treating our most complex patients, the congestive heart failure patient, is a very, very serious action. The care of this patient is extremely difficult. It requires significant investment in time, specific expertise in the cardiac problems associated with that patient, and tremendous effort to keep that patient alive and out of hospital. Ontario, if you go ahead and do this, you're picking on the most vulnerable cardiac patient, and their care is going to be seriously jeopardized unless there's a change in this regulation before it comes into effect. For more than a year, the Ontario Association of Cardiologists has been concerned about the cardiac care for the heart failure patient. We've been told by government that this is the most expensive patient. So we got together the experts, and I tell you that in the Ontario Association of Cardiologists, we have the experts. We have the best in the world. You can read the papers. They've published. They're respected throughout the world. These are the people who have contributed to what I'm telling you today. So what we have done is we have worked on a heart failure project, and that heart failure project is designed to improve the care in Ontario. The problem with the 078 code is you think it may not be properly defined. We found out about this on the 13th of January. We called together the Ontario Congestive Heart Failure Working Group, again made up of the ladies and gentlemen across our province who deliver this care, not only in the university but in the community setting. And we have language that we think we can share with you that would more than cover off how the congestive heart failure patient needs to be treated by whatever specialist is going to. Because you have to remember, it's not just the cardiologist that treats these patients. Nephrologists, internal medicine people, others treat this patient. But please do not ignore this patient. The other thing that we've been doing with our experts is we developed a pilot project because government asked us to try and come up with something that would work. So our experts put together a pilot project, and this pilot would be rolled out in 2 communities, in Ottawa and in Peterborough. And the project is very well laid out. And if you look at the costs, and it seems that what we're interested in, and you're the budget committee, is you want to know about money. So if we have an uncomplicated patient and we keep that patient out of hospital, we save $12,000. And we have the data to provide to you should you want. We're happy to share it with you. The complicated patient is going to cost you a minimum of $42,000. Keeping the patient out of hospital, improving the quality of their care is our goal, and this is what we as cardiologists strive to do each day. Also, it's going to improve the quality of life of our patients. What's better than that? Improve the quality of life, prolong their life, and make them happier. So, what we would like you as a government to consider is the cost of this project is $3 million for those 2 centers. Spend the money. You'll clearly see that the benefits are there. And then once the pilot, and you believe in the pilot, and it'll only take a few months for the data to come forward, this pilot can be put anywhere in Ontario. And it's not designed to displace programs that are in place. It's designed to complement them or put it in a place where it hasn't happened before. So the next thing that we want to do, and this is something we presented to you back in 2012, you'll remember the Liberal government passed some unilateral regulations about the definition of self-referral. That would have put out of business the non-invasive cardiac labs, whether they lie in the university or in the community. 80% of them would have been gone. We came to you then with a solution. There was a paper that some of us were authors, and it was called the Standards for the Provision of Echocardiography. And it showed if you put those standards in place and you followed appropriateness guidelines, ISIS independently analyzed our paper and said we could save at least $44 million. We went to the government, I'm talking we, the Ontario Association of Cardiologists, without the support of the Ontario Medical Association. And we said to government, we care about our patients. We want to make sure that this network that we have in place in Ontario doesn't deteriorate. But most of all, we don't want to see patients die. And I'm sitting in this chair, and unfortunately, I've seen patients die on the waiting list. And I promise you, it's not a pleasant sight. The government agreed with us. They liked our standards. They liked the work that we'd done. They saw that the research was peer-reviewed, and they said, we'll change the definition of self-referral to appropriateness guidelines. The problem we've had is since they've changed it and we've tried to implement this program, it's been going extremely slowly. So what we would like you to do as a government and as a committee is to encourage them to implement these standards. And following the standards, we should have appropriateness guidelines for the testing. You've all heard about choosing wisely and appropriateness things. These are the things that we as clinical cardiologists believe in, and other physicians outside of cardiology believe in them as well. We think if you follow that course, you can save significant amounts of money, help pay down your deficit, and also improve and protect the care that we deliver each day. The types of technology are very sophisticated in cardiology today. We have echocardiography, stress tests, ECGs, Holter monitoring, MRI, PET scanning, and CT angio. If you follow what we're suggesting here...
presentation.
Okay, I'll just close. So the last thing is, we as cardiologists think if we work with you in a cooperative way, that we can do more together than we can apart. And we're here to offer our cooperation to work with government in this committee to make the things we've talked about today reality and to protect the cardiac patient.
Thank you. Ms. Fife, you want to begin the questioning?
Thank you very much. Good to see you again. James, I sort of associate you with the by-election in Kitchener-Waterloo because that's where I first met you in a Tim Hortons.
That's right.
And you were talking about many of these issues then.
Yeah.
But I want to focus on the situation right now that we are in the province and taking all your recommendations into account. But the contract that the government has imposed on doctors eliminates the 50% premium payment on fees charged by cardiologists, amongst other specialists. The government says that these higher payments are no longer relevant. And language can be very powerful. So what was the purpose of the premium in the first place, and what does this mean to you when those premiums are...
Well, the premium, when you see a patient in the office or you see a patient in a clinic, there's a professional fee, and that fee is designed to cover the overhead to deliver that particular service.
That's right.
So when you have to deliver a very complex service, it takes time and effort and support. So if we lose that 50% premium, then we can't provide that service in the outpatient environment. That's the risk. And the other risk is that these patients are very, very tenuous patients. They require very careful monitoring. So this, to us, is very, very upsetting. And it means that the network that we currently have in place, whether it's in a hospital or in a community setting, that we will not be able to deliver that service indefinitely. You'll get it for a little while, but then we won't have the money to do it, and the patients are going to suffer. And I'll tell you, these patients are brittle.
Yeah. Well, you made the point about muscle. When you lose muscle, you lose that potential. So the government also says, James, that they're going to work to develop a savings methodology that results in a higher proportion of savings from higher paid specialties. And this was recently in the news, I think just last week. Has your organization been consulted on this savings methodology, considering that cardiologists are amongst the higher paid specialties? So I want you to go on the record on this, please.
We haven't been consulted formally.
You haven't been?
No.
So okay. In the past, you've raised concerns with this committee. This is your third time appearing before this Finance Committee in the last 3 years, about the way that HealthLinks program was rolled out and the fact that cardiologists weren't involved at the beginning. The government says they're expanding the HealthLinks program. Have your concerns been addressed around the gaps in service, the disconnects in the HealthLinks program?
Well, that's what the congestive heart failure pilot was designed to do, because we felt we'd been left out. So we actually went to government and we told them we'd been left out. We asked how we could work together, and over the last year we have worked together with the experts to put this, and we presented it and gave it back to the Ministry of Health about 10 days before the regulations came forward in January. The word that I have, the preliminary feedback, is that they thought the proposal was extremely sophisticated and it had a lot of merit, and they said that they would like to explore it further with us. So I think that's a positive reaction
And I
there.
remember you talking to me because at the time it was the Minister of Health, Deb Matthews.
Yes.
And I remember the numbers that you presented. It was a savings of $44 million around the self-referral
Right.
piece. So, it makes sense. We've already invested all this money in these patients. For them to get to this point in their patient-centered care, for us to drop the ball, it doesn't make
So
sense.
we're committed to implementing the standards. There's only a few echo labs in the province that we've been able to do it so far. The cardiologists, and I can speak for not only the members of OAC, but there are other cardiologists, we all want to see those standards in place. We all want to see the appropriateness guidelines. The problem is that we haven't had the resources on the government side to move that forward. And one of the things that we've asked here is please put those resources in place. Please move that forward. There are tremendous savings there. I'm sure there's more savings there that we need that we could cover off this EO78 code. But we have to work together. And if we don't work together, this cardiac care system is going to fall apart.
That's right. So it seems to me that you've come to the table with this proposal and that based on the pilot, it makes sense. Just for clarification, though, does this year's imposed contract remove additional funding for ECGs?
It's across the board, everything we do.
Yeah.
It's 3.15% across the board. The other thing I would really encourage members of this committee to do is go to the website ontarioheartdoctors.ca and look at two items there. Look at a day in the life and look at Winona's story. And it clearly outlines how we treat patients across this province and how we improve and save their lives. And I think when you look there, you'll see why we're so concerned with what's come our way in the last few days. And we are going to speak out publicly and protect our patients.
Well,
We'll do the best we
Thank you very
can.
much, James, for
Thank you.
coming in.
Thank you, Dr. Swan, for your presentation and your
Always.
written submission.